All right, guys, I'd like to welcome Dr. Kristopaitis back. She's going to be doing a lecture on pain management in patients. So take it away. Thank you.
All right, thank you. So I have a fair amount to cover. If you have questions, please ask. And if we don't get through the whole thing, that's fine. So without further ado. Okay, disclosures, none. I'm talking about different drugs and but I have no disclosures. I don't have investment in Purdue Pharma, which would have been a bad idea anyway at this point. I am having, I can't. So our lecture objectives are to summarize principles of managing pain, to apply the CDC guidelines from 2016 for the management of non-malignant chronic pain, and then develop safe strategies for using opioids. All right. So my 12 pointers, that's sort of how I formulated this. So first, you have to obtain a comprehensive history and physicals. We're not going to go through all the details of giving a history and physical, but why is that important? How you manage pain. Now, the workup is one thing. We're not talking here about workup because clearly the nature of pain is going to dictate how you do it. But if we're going to focus on the management and the pharmacologic management, there's so many things you have to take into account in this day and age, right? Is it acute or chronic pain? That may influence how you manage it according to guidelines. Is a patient healthy? Do they have renal dysfunction? Do they have other acute physiologic compromise? Is this acute on chronic pain? They have chronic pain and now they present with, some kind of an exacerbation, a new kind of acute pain. Is this cancer related? We should treat our cancer patients as cautiously with respect to opioids, but if someone is getting active cancer therapy or is approaching a point in their life where they have advanced disease, we may tip the scales perhaps to focusing more on opioid therapy if other modalities are not working. Is this neuropathic pain? Is this somatic pain? Is this visceral pain? That will help you decide perhaps the best approach to pharmacologic therapy. Is the patient at risk? If you are thinking about using opioids, are they at risk for increased harm because they have substance use disorder, or they have maybe upon screening a propensity for substance use disorder? So all of these things kind of do come into play and into mind when you're starting to think about how to manage someone's pain. So our CDC guidelines for the management of chronic pain. How many of you have heard of these, or at least are aware that the CDC issued guidelines? Show of hands. Okay, so in 2016, because of the opioid epidemic, patients have been dying in huge numbers of opioid overdose, and there are growing numbers of opioid addiction. This was probably the most one of the most talked about topics in society and medicine. If you open up any newspaper before COVID hit, and COVID kind of took this away a little bit out of our discussion points, but nonetheless, it remains a problem. And COVID-19, has impacted, substance use disorder issues, but, we're not going to get into that in depth. So the CDC issued guidelines in 2016 really geared towards primary care providers. And that's the group where patients most often present with chronic pain. Yes, sometimes subspecialists, but they have the primary care provider in mind. And from these guidelines, they sort of excluded patients receiving active cancer chemotherapy. Not that we shouldn't be cautious with them. Maybe the risk benefit's a little different for someone who has non-malignant pain, and patients at the end of life. And so the people they sort of thought about in this guideline were those with chronic non-malignant pain, chronic back pain, DJD pain, neuropathy, diabetic neuropathy, fibromyalgia, chronic abdominal pain, other forms of chronic non-malignant pain. So large document, I think a well-written document, but if you take away some of their key points for chronic non-malignant pain, they recommended that initially, depending on the nature of the pain, you try non-pharmacologic therapy first. So give me some approaches to non-pharmacologic therapy. Acupuncture. Physical therapy. What's that? Ice packs, ice pack, cold pack. Meditation, hypnosis, massage, distraction, all of those are non-pharmacologic therapies. Now, sometimes there's a problem because they won't get paid for. If a massage a day helps someone, they may not have the finances to do that. Acupuncture has limited coverage. For example, for Medicare patients, they have a very strict guideline on covering acupuncture for low back pain for a defined period of time if there's evidence that the acupuncture is working. So some of these non-pharmacologic modalities, aren't necessarily the most realistic for some of our patients, but nonetheless, think about them and try them first. Then, if that is not helping, try non-opioid pharmacologic therapy. And we'll get into that a little bit more, NSAIDs, acetaminophen, some of the adjuvants. If at some point the decision is made to use pharmacologic opioid therapy, that should be after a detailed analysis of the risk-benefit ratio and by setting up goals, not just what is your number, but really functional goals. And so they really emphasize it's not just about, what's your pain on a scale from 1 to 10 today, but let's see how pain is impacting your enjoyment of life and how pain is impacting your function. And then we can come up with a game plan. So some other points from the guideline when starting opioid therapy for chronic pain. And I think this is also appropriate for acute pain in patients with cancer. So I think, these principles apply for kind of across the board. Establish treatment goals with the patient that are realistic. And again, focus on their ability to function. So, if they're able to get up out of bed, go to work, drive their kids to school, but they say their pain's a 10 out of 10. Yes, we have to believe that, but our therapy is working to a certain point because they're functioning as they should be. The guidelines outline this PEG assessment scale, which kind of hasn't quite hit prime time, but having a patient think over the course of a week, what's your pain been on average, 0 to 10 scale? How is pain interfering with your enjoyment of life? How is pain interfering with your general activity? And so over the course of time, if you're budging that scale, so a total of 30 points, if you're getting lower and lower, whatever you're doing is working. If what you're doing isn't budging that scale, especially if you're going up on opioid therapy, probably not the right approach. We have to think differently. So again, continue opioids only if there is meaningful improvement in pain and function. Again, I think that applies to the inpatient setting for acute and chronic pain, as well as the outpatient setting. Long-term opioid use may begin with that first dose of Norco that you give somebody. That's the bottom line. This wasn't so much focused on acute pain, but they have some guidelines on acute pain. When opioids are used for acute pain, acute post-op pain, prescribe the lowest effective dose. That will work. And use immediate release formulations. We're going to talk about that again. And, don't have to write a 30-day prescription. Give them a 3-day supply of the opioid if you think the nature of their pain will be such that that severity of pain will last 3 days. Give them 7 days, give them 10 days. But again, this is not a carte blanche to give them, an open-ended supply. If patients are still having pain after their 7-day supply is done or their 3-day supply, then you probably need to reevaluate them or discuss with them what is going on. I thought your pain would be better by now. Let's see what's happening. Okay, who has heard or used the Illinois Prescription Drug Monitoring Database to this point? Okay, not everybody. So if you are going to prescribe opiates as an outpatient to someone, you need to check the Illinois Prescription Drug Monitoring Database. I also check it often when I'm going to prescribe opioids to someone on an inpatient basis. And so what the Illinois Prescription Drug Monitoring Database is every time a patient fills an opioid, some other related drugs, it will be appearing in this database. Is it perfect? It's not perfect. Doing a lot of opioid prescribing in our palliative care world, there are times when the drugs do not appear in a timely fashion, but most of the time they're there. So this is an example of a patient we saw. I don't have the patient's name or the provider, but when you click in, and where can you find this? I usually look for it in the Discharge Navigator. That's where I seem to find it easiest, unless you find it someplace else. If you're doing a phone prescription, you're going to have to, it'll appear in the phone encounter. But you can see the drugs that they've received: cyclobenzaprine for this patient, gabapentin, hydrocodone, acetaminophen, morphine, tramadol. So I just exploded Norco for you. So you can see when the prescription was written, when it was dispensed, the strength, how many they were issued, and what kind of a supply was that. So you can see, this was developed in part to see if patients are seeing multiple providers and getting multiple prescriptions from multiple providers, but nonetheless, kind of helps you get a sense of, where they're filling and when they're filling and who's prescribing. Any questions about this? And when you do look, you can, hit mark as reviewed and closed. If you don't do that for an outpatient prescription, it'll give you a stop. So again, kind of just summarize our pain evaluation, all those things you've learned about the PQRST. But again, remember that to ask the patient, how is the pain impacting you and your function? That's really a key component. Okay, point number 3, know your analgesic. So I'm going to go through drugs you've learned. For some of you, this will be clearly a redundancy. For some, it'll be hopefully dusting off some cobwebs. So the World Health Organization developed what they call a 3-step pain ladder. So they took analgesics and they divided them up depending on a patient's severity of pain. Step 1 for mild pain, step 2 for moderate pain, step 3 for severe pain. And in addition, they said, consider using an adjuvant, and we'll talk about adjuvants in a bit. For step 1, for mild pain, even if it's severe pain, you may try a step 1 drug. Acetaminophen, nonsteroidals, and aspirin are the 3 drugs in that first step. How much acetaminophen should someone not exceed in a 24-hour period? 4 grams. People are shooting more towards 3 grams because NSAIDs or acetaminophen at chronic high doses, not necessarily an intentional overdose or non-intentional overdose, can cause liver disease. So 3 to 4 grams should be the maximum from all sources. They're Norco, they're Tylenol PM, they're Tylenol for fever. Step 2 drugs. So this is for patients with moderate pain. Perhaps if the mild step 1 drugs aren't working, then we can escalate. If you're going to use opiates, again, you've done that risk benefit analysis. And now, we are embarking on a journey with the patient on opioids. So the step 2 drugs are coating with acetaminophen, and I have the generic and the trade name so you can relate them. Tylenol number 2, number 3, and number 4. Codeine is actually an inert drug. When someone takes codeine, nothing happens until it gets to the liver. It is metabolized to morphine. So patients who are taking codeine are actually getting a low dose of morphine. Hydrocodone plus acetaminophen is a step 2 drug, and some of the trade names are Norco, Vicodin, Lortab, Hyset. They come in liquid formulations and tablets here at Loyola. Then we have oxycodone plus acetaminophen. When oxy plus acetamin are together, that is called Percocet. So that is the combination drug. And you'll see oxycodone as a step 3 drug, but for codeine with acetaminophen, hydrocodone with acetaminophen, oxycodone with acetaminophen, what's the maximum amount of the drug that you can prescribe? What's it based on? You can't exceed the maximum dose of acetaminophen, right? So there's a ceiling to how much you can provide. If someone is taking a combination product and they're taking it multiple times a day, pretty soon they're going to exceed that 3 to 4 grams. So there is a ceiling to these drugs. And the last drug in the step 2 ladder that we most commonly use is tramadol, also known as Ultram, is one of the trade names. Any questions about this? So the step 3 ladder, so this is for patients who have severe pain or the step 1 and step 2 approach hasn't worked. And so we have our potent opiates, morphine, hydromorphone, also the trade name is Dilaudid, oxycodone by itself. So as a step 2 drug, it's combined with acetaminophen. Step 3 drug, it's by itself. Methadone is an opiate that we use for pain. So it's not just for patients who have opioid addiction, and fentanyl. So morphine is available IV, PO, anesthesiologists use it in blocks and epidurals. Hydromorphone, same routes. Oxycodone is only available PO. Methadone is available PO and IV. And fentanyl, how is fentanyl administered? What are some of the routes of fentanyl? Patch, so transdermal. IV. So you may hear we don't, I don't prescribe it because if you want to prescribe, we call transmucosal fentanyl, fentanyl on a stick, fentanyl lollipops, intranasal fentanyl, fentanyl lozenges, you actually have to go through an extra set of modules by the FDA called risk mitigation modules. So fentanyl transdermal, fentanyl IV, you can prescribe with your current hospital license. But if you're going to do something like fentanyl transmucosal, it's sort of an extra certification to really make sure that it's being used safely. So these are the step 3 drugs. All right. So adjuvant analgesic. So the term adjuvant means that it's a drug that was developed for something other than managing pain. But as we learned about pain mechanisms, as we learned about the drugs themselves, we learned that some drugs can be helpful, though they're not true analgesics for helping pain. So for example, neuropathic pain is, not responding very well to opiates for sure, NSAIDs, not so much, even acetaminophen. So we have a range of neuropathic drugs listed here that range from antidepressants. So they were never developed for neuropathic pain, but now we probably use the tricyclics more for neuropathic pain than as an antidepressant. You can see SSRIs and SNRIs on this list, or SNRIs. So again, antidepressants being treated for neuropathic pain, anticonvulsants, gabapentin and pregabalin for neuropathic pain. For bone pain, metastatic bone disease, CNS headaches because of edema, masses, dexamethasone is considered an adjuvant, and then you could see some of the others. Just a point that if someone has, for example, severe neuropathic pain, most of the time we start someone on anticonvulsants, but if they're still having neuropathic pain, you can pick a drug from another mechanism, like an antidepressant, and combine different mechanisms as the adjuvant stand. So when we say use non-pharmacologic therapy first for chronic non-malignant pain, and then we say use non-pharmacologic therapy or non-opioid pharmacologic therapies, these are probably some of the drugs we're going to go to. But just know that there's more literature coming out, that there's maybe an addictive potential to pregabalin, maybe there's an addictive potential to gabapentin. There's an increased risk of prescribing opioid with pregabalin. So, as we are trying to find ways to help our patients, we're getting more literature on maybe some of the harms. But nonetheless, these are things to consider for patients for whom an opioid may not be the only choice, or add this on in addition to an opioid to help someone's pain. All right. Respect the potency of opioid analgesics and starting doses. So this is, you got to know what you're doing with opioids, and sometimes, you have to brush up on, what's really the starting dose. So always start with short-acting opioids. We're going to talk a little bit about long-acting opioids, but always start short-acting opioids. Are there situations where we'll start long-acting opioids that last, 24 hours to 12 hours? Yes, but that is the exception rather than the rule. So always start immediate release short-acting opioids. So how do I know what dose to start in a patient? Well, there's recommended starting doses, but you also want to take a look at the age of the patient. And the older we are, metabolism changes, start lower, go slow. Weight of a patient, very frail, thin patients, you may err on the side of starting a lower dose. Comorbidities, renal dysfunction, liver dysfunction come into play when you're picking any analgesic, but opioids, prior experience, if a patient who has issues with pain tells you, 6 milligrams of something works for me better than 2, we have to be cautious, but sometimes their experience, what they're telling us is effective, comes into play. And then the severity of the pain and the frequency. So things to keep in mind. So for this list of drugs, tramadol, hydromorphone, oxycodone, hydrocodone, codeine, and morphine, I want you to think and tell me which of those drugs is the least potent, and then jump up the ladder and tell me who's next potent to the most potent. So of these drugs, which is the least potent? Tramadol, probably not, but close. Who's even less potent? Starting dose for starting dose. Codeine. Then tramadol. How about after tramadol? Who's next most potent? What's that? Morphine, and morphine is equianalgesic to hydrocodone. So morphine and hydrocodone are equianalgesic. Then who is more potent? Oxycodone or hydromorphone? Oxycodone is next most potent, and then the most potent of this list is hydromorphone. So just so that you can kind of get a sense of, who's more potent than somebody else. So an equianalgesic table is really key. So I carry one with me in my pocket, especially I'm doing palliative care consults, but I think if you are on the ONC service or, going to be somewhere where you might be prescribing opiates more than not, you have to have a table with you that you are comfortable with. So this is an example of a table. Is every table going to be the same? No. The story on opiates is not done. So people are still doing studies on the pharmacokinetics of opioids, really what is their relative potency, PO to IV. But this is an example of an equianalgesic table that I use. So it gives you the oral dose and the relationship of the oral dose to the IV dose. So morphine IV is 3 times more potent than oral morphine. So there's a ratio of 30 to 10 or 3 to 1. So hydromorphone to morphine oral, you can see that the potency of hydromorphone is 4 times more potent than oral morphine. So I can start to get the sense of the relative potency. So when we start doing equianalgesic conversions, when you're taking someone from one opioid to another for whatever myriad of reasons, these tables are necessary to do some dose conversions, and we'll do a couple of them. Questions about this? How many of you have a table that you're used to, comfortable with? Okay. And the thing I don't recommend is you just go into your calculator and find some calculator who'll do it for you. That's fine. But if you don't know what they've put in terms of their potencies, if you're talking about a starting dose of a drug, fine. But if you're on ONC and someone's hundreds of milligrams of something, I don't want to throw caution to the wind and just use someone's calculator unless you know where it came from and you know what their table looks like. So, find one, pick one, and go ahead and use it. Yes.
How do you deal with different efficacies, different if the ceiling effect is different?
So, okay, with the step 2 drugs, which are combined with Tylenol, you have your ceiling. It's based on Tylenol. But all of these drugs, the ceiling, how much you can prescribe is really based on patient's tolerance. So there are patients who are tolerating hundreds of milligrams of morphine a day, but that's because we've slowly titrated and we know that the side effects are not outweighing the benefit. There is something that's well documented, is that patients, after they reach a certain amount of drug, and it's different for everybody, they may actually develop hyperanalgesia. So the more you titrate the opiate, they may actually start experiencing more pain. It's this unusual phenomenon with sort of oversaturation of mu receptor. At some point, patients may not benefit from more opioids. So it's either the side effects that sort of you reach the ceiling, or this hyperanalgesia that they may develop. Did I answer your question?
I'm more about when you're doing a conversion.
Oh, conversion.
If you're let's say, I don't know the pharmacology, I'm just let's say oxycodone and morphine both have different ceilings in terms of efficacy. How do you do a conversion of those higher things?
Yeah, we'll go ahead and do a couple simple conversions and maybe it will answer your question. If not, get back to me. Okay. So just to get your hands on some starting doses, this is my approach, it'll differ depending who you read. Codeine, 30 milligrams, that's 1 Tylenol with codeine. Tramadol, 25 to 50 milligrams. Morphine and hydrocodone, about 5 milligrams. Now beware that if you were to order morphine oral, the tablet, that is 15 milligrams in strength. So here the tablet's 15 milligrams. That's 3 times more than the starting dose. If you're going to start morphine and you're going to start at a starting dose of 5 milligrams, you may have to use the liquid so you can actually get 5 milligrams. So I've seen residents just order 15 milligrams of morphine from the get-go because that's the lowest dose that we have, but that is not the starting dose. Oxycodone, if you're using the potencies, starting dose is about 3 milligrams. Oxycodone comes as a 5 milligram tablet. So, if someone's having more severe pain and, they have good renal function and they're not particularly old or frail, you can probably start the 5 milligrams, or you can cut a 5 milligram tablet in half and get 2.5 milligrams. Then the starting dose of oral hydromorphone is about 1 milligram, and the lowest dose of hydromorphone tablet is 2 milligrams. So either, give 2 milligrams if you're comfortable, or you have to cut the tablet in half. Questions? And this is assuming normal renal function and liver function. Question? So a couple of factors. One, something that you're comfortable with and Number 2, if a patient tells you that, I had tons of nausea for morphine, I don't want morphine, then you may then respect that and, try hydrocodone or oxycodone. So it's a 2-factor. When you're starting to get out of the hospital setting, sometimes insurances will dictate what you can prescribe. They will require pre-authorization for some drugs. So, Norco, hydrocodone is pretty easy to initially prescribe. So lots of factors. patient's experience, your experience, what's on your, what's approved by the patient's insurance, kind of all come into play. We're going to talk a little bit about renal and liver dysfunction, and that may also impact what you're going to start. That help? Other questions? So effective IV doses, you're going to be using IV here. So a starting dose of morphine, generally, in the population that we work with, often older and frail, about 1 milligram IV. Now respect the potency of IV morphine and IV hydromorphone. So if you look at your equine analgesic table, morphine and hydromorphone is 6 times more potent than morphine IV. So if you're going to start 1 milligram of morphine on someone, that's about 0.15 milligrams of IV Dilaudid. So if you're just going to throw caution to the wind and prescribe 2 milligrams of Dilaudid, that's about 12 milligrams of morphine. And no one's going to start 12 milligrams of morphine IV for the first time when the starting dose is 1 milligram. So again, you kind of have to get your hands around how much more strong one drug is over another. Questions? Okay. So when switching from one opioid to another, a new drug have unexpectedly strong effects. Maybe this is getting to the point that you were asking. So if I am going to take someone who is on high doses of morphine, and let's just pretend and we're doing IV, and I'm not saying that this is what we would do. So someone's on 60 milligrams of IV morphine, and we're going to convert that to hydromorphone. So 60 milligrams of hydromorphone divided by 60 milligrams of morphine divided by 6, that's about 10 milligrams of IV Dilaudid, if that's, just a random scenario. So that fits the analgesic table that hydromorphone is 6 times more potent than morphine. So could I just give 10 milligrams of IV hydromorphone? Yes, but the slide that I just came from says that when you are switching from one opioid to another, especially at high doses, as our mu receptors get saturated, there's lots of different mu subsets. So morphine may work on subset 1, 2, 9, 14, 15. Dilaudid hydromorphone may work on 1, 7, 8, 9, 14, 15. They may have some mu receptors in common, but some mu receptors not in common. So as you switch to a new opioid, you may actually get more analgesia than you were expecting. So you have to take that into account. If I'm using starting doses, probably not. But if you're on 60 milligrams of IV morphine, switching to 10 milligrams of Dilaudid, you need to maybe expect that 10 milligrams of Dilaudid may give someone far more analgesia than you had anticipated. So that's called adjusting for incomplete cross tolerance. So one opioid switch to another is not necessarily based strictly on the table. So you may want to calculate the equianalgesic dose, but then decrease it by a factor from 25 to 50%. If someone's pain is super well controlled on morphine 60, you convert them to 10 of Dilaudid IV. You may want to cut that down by 50% because their pain's really well controlled. Only give them 5 milligrams of IV hydromorphone. If someone's pain is still not very controlled on 60 of morphine, you switch them to 10 of Dilaudid. You may want to decrease that by 25% and give them 8 of Dilaudid. So again, that's adjusting for incomplete cross tolerance. Patients may not tolerate the same opioid the same way. Did I answer your question now? Okay. Questions about this? So in the palliative care consult world, we're always adjusting for cross tolerance. The factor will depend on how the patient is doing. Are they already sleepy? Are they in a lot of pain? And that influences whether we decrease the dose that we calculate from 25 or 50% or more. So just a few notes on tramadol. How many of you have prescribed tramadol thus far in your series here? So just a few notes on it. It is a mu receptor agonist like an opiate, so it's like an opioid-like drug. However, it is a serotonin and norepinephrine uptake inhibitor. So it has SNRI properties as well. And serotonin and norepinephrine, as they float around, decrease the modulation of pain via the descending pain cascade. So it has a role in pain management. Talked about the potency. It's a little bit more potent than codeine. So it is not the weakest of the opioid-like drugs. And when it was initially marketed in 1995, the FDA listed it as a non-controlled substance. So you could prescribe it like labetalol and, diabetes drugs. And because the studies suggest it was safer and non-addictive. We have learned since then that that is not the case. And now tramadol is a controlled substance, just like all the opioids that you would be prescribing. some adverse effects. So it's not the safest drug. You know, opioids have all their issues, but tramadol is not, you know, oh, I'll go with the safest one. Can cause serotonin syndrome if it's prescribed with other SSRIs or serotonin uptake inhibitor drugs. Debated in the literature, but it can lower the seizure threshold. So if someone has known seizures, if someone has something in their brain that can leave them at increased risk for seizures, I would not use tramadol. There are reports of patients with diabetes on oral agents presenting with hypoglycemia. And, you know, after evaluating the patient, it's just due to some effect of tramadol on the anti-hypoglycemics. I don't know further details, but again, patients can present with hypoglycemia. So that may be a clue if someone's on tramadol. If you quickly stop tramadol, if someone's been on it for a series of weeks or months, they may go through withdrawal syndromes like they do when you stop an SSRI. And there is an addiction risk. So that initial thought of no addiction risk has not proven to be true. Assume it has the same addiction risk as any of the other opioids. Questions? Okay. So point number 5 out of 12, describe the principles of opioid dose escalation, meaning how much can I increase the drug when the dose that I have prescribed somebody isn't working? So the recommended frequency and the amount of dose escalation depends on the peak effect and the half-life of the drug. So an IV opioid, when you give an IV opioid, when does it set in? When will someone start feeling the effect of an IV opioid? Roughly 5-10 minutes. I'll start feeling the effect as an IV bolus. The IV opioid effect probably peaks at 30 minutes, assuming normal renal function, all that. So if you wait more than 30 minutes after the dose, if they didn't get help at 30 minutes, probably more time will not help that drug kick in. So keep that in mind. Short-acting oral agents, if you give someone a Norco, an oral Dilaudid, an oral morphine, when will it start kicking in? When they start feeling better from that opioid dose? How much? Probably a little bit longer, about 30, 45 minutes, maybe even an hour, depending. They'll probably have a peak effect at about 2 hours. So, you know, if that dose of Norco didn't help them at 2 hours or relieve their pain, probably not going to do much more as the 2 hours start to progress. Sustained release oral opioids, I'll talk about it separately. So, you know, have a sense of when the drugs kick in and what the peak is. I'm gonna go to the next slide. So if someone is admitted with moderate to severe pain, they have ongoing moderate to severe pain, you can increase the opioid dose by 50 to 100%. And I'm thinking of someone who has an acute pain crisis, right? Not someone who has some mild pain and over time you're going to titrate opioids, but they're in the hospital, they're on the ONC service or another service, and they're having severe 10 out of 10 pain, can't function. You can titrate pretty aggressively, again, with caution. If at the time of the peak effect of the drug, their pain is moderate to severe, you can increase the dose by 50 to 100%. So if you give a dose of 1 milligram of IV Dilaudid, and about 30 minutes has passed and they're still writhing in pain, no better, theoretically, you can increase the dose by 50 to 100%. You can give 1.5 to 2 milligrams, even at the 30-minute mark, if someone is really in that acute of a crisis. Now, if they're kind of hanging out, you're trying to manage their pain and perfect it, I wouldn't be this aggressive. If someone gets a dose of an oral hydromorphone and then about 2 hours, they have had no effect or they're still feeling terrible, you can double the dose, go 50 to 100%. Someone's having mild to moderate pain, the rule of thumb is increased by 25 to 50%. Again, this is aggressive, but this is someone who maybe the priority is to control their pain, and that's the reason why they've been admitted. An outpatient basis will be far more conservative. Questions? I just want to go back to the prior slide. So sustained release oral opiates, we'll talk about that in a little bit. They should not be titrated more than every 24 to 48 hours. And transdermal fentanyl should probably, the dose theoretically should not be changed for 72 hours. So I see a lot that patients, we're cranking up their fentanyl doses, more than every 72 hours, but that would be the rule of thumb in terms of dose escalation. Okay. So I see residents, sometimes we're doing palliative care consults and someone is on Norco, that didn't work, so they added morphine, then they put them on IV Dilaudid and some IV morphine, and they keep on switching around. And so this, what we call rotation to another opioid, really isn't necessary. Pick an opioid that you're comfortable with, that the patient's tolerating, and work with that. Switching from one opioid to another isn't necessarily going to help the patient more than starting with one and working with it. Now, is there, do different opioids respond differently in different people? Yes, there are studies on pharmacogenetics and pharmacogenomics. And, you know, one opiate may work for someone great and one may not work for someone. But that's, you know, through some trial and error. But just giving 2 doses of morphine saying, oh, it doesn't work, I have to switch to Dilaudid, it's probably not, you know, pharmacogenomics at play. That's probably, we just didn't dose titrate the drug sufficiently. So as long as you see some response, stick with one drug. Or if the patient's not tolerating it, they develop horrible nausea. Yes, all opiates can cause nausea, but if they are just horribly nauseous, or, you know, become confused, you know, that may be a sign that maybe you should switch an opioid sooner rather than later, or they provide information that, oh gosh, I remember I got hives from morphine, you know, don't continue the morphine. That's a good reason to switch the opiate. Okay, math time problem. So a patient has gotten several doses of morphine, 2 milligrams IV for severe pain. Pain is unrelieved. So your resident tells you, go ahead and change it to 2 milligrams of IV Dilaudid. So they're switching an opiate and picking a dose. Is this a good plan? You're going to do what your resident told you, or be at risk for insubordination? What do you think? Yeah. Got to use a calculator, got to do the math, right? So, you know, you may start getting a thought about what to do. So, hydromorphone, 2 milligrams IV, because that's what they switched him to or her to, is the equivalent of what dose of morphine? So we'll go through the calculation together. So 2 milligrams of IV hydromorphone. Remember that table I showed you? You set up a, I don't know if you did this in chemistry or geometry or somewhere in algebra. You set up a your equation. So 2 milligrams of hydromorphone is equal to 1.5 milligrams of IV hydromorphone and 10 milligrams of IV hydromorphone. Using your equianalgesic table and setting up a calculation to determine the result of transitioning hydromorphone to morphine. So 2 milligrams of hydromorphone times 10 divided by 1.5 is what? What's 20 divided by 1.5? Surely someone can do that. Yeah, 13 milligrams of morphine. So by giving someone 2 milligrams of IV Dilaudid, you are giving them the equivalent of 13 milligrams of IV morphine. So to go from 2 to 13, does that follow any equianalges, any titration principles we discussed? We said can go up by 50 to 100%, 25 to 50%. This is a 200% increase. This is far beyond what we should be doing. So by saying, oh, switching from 2 morphine to 2 Dilaudid, that is completely unsafe. Question?
Did you say to cut it in half or 25%?
So you can. So this is still a pretty low dose. So I might not be so finicky about cross tolerance at these starting doses. Could you? That would be the safest. But I would probably be okay saying if I was going to switch them to hydromorphone, I could take and the 10 milligrams. Let me go back to my original question. So 2 milligrams, 2 times 2 divided by 6 is whatever, 1/3, 0.3. I'd probably be okay given the 0.3. I probably wouldn't decrease for cross tolerance at these small starting doses. Not wrong, but you know, we're starting to talk about, you know, they're on higher doses. There's no particular cutoff. Questions? Okay. Then patient comes and tells you, oh, I had a horrible reaction to morphine. Okay to switch. So what I would have probably done is, you know, taken that 2 milligrams wasn't helping, double it, 4 milligrams, or go to, you know, 3 milligrams. Dose titrate the morphine before you start switching around. But if a patient has an adverse effect or tells you they didn't tolerate it in the past, I would go ahead and respect that. Yeah. So 0.3 milligrams of hydromorphone is what would have been the calculated dose. Okay. So a little bit on long-acting agents. So the bottom line is extended release or long-acting agents are not for acute pain management. Remember I said start with immediate release agents, not long-acting agents really in any scenario unless you are skilled and have a good reason for not starting immediate release agent. This is from the CDC guideline. Reserved for cancer pain, reserved for patients who are, involved in a palliative care program. So maybe the risk benefit is, appropriate. And conditions associated with persistent disabling pain with functional impairment. So someone with bad DJD who's still kind of hobbling around, someone with diabetic neuropathy who's, do okay on some, gabapentin. Those are not the patients where you want to start long-acting agents. Double check this because everyone asks, well, wouldn't long-acting be safer because it kind of lasts longer and there's not these peaks and valleys and maybe buzzes and highs? The answer is still no. We're starting to really appreciate that long-acting agents are not for patients other than in some very specific categories. So what are some names of long-acting opioids? Well, morphine comes as a long-acting form. So you've seen and heard the names. MS-Contin is the brand we have here. That's dosed initially every 12 hours. Kading and Avinza, we don't have on formulary, but someone may come in on it. They're dosed every 24 hours. So again, instead of taking something that has to be dosed every 4 hours, so short-acting agents peak at 2 hours and probably start waxing and going away at about the 4-hour mark. So if you're on a short-acting agent, probably dosing every 4 hours with normal renal function is what you want to do. But if someone is needing to be on something every 4 hours for years because of their malignancy or whatever, that's hard to do. And if they don't take the drug, they have pain, that's where these long-acting agents have been developed. So you can take something every 12 hours or every 24 hours instead of every 4 hours. Oxycodone's long-acting form is OxyContin. Hydromorphone, we don't have on formulary, it has a long-acting form, and transdermal fentanyl is a long-acting opioid. Long-acting opioids are patients with cancer, in palliative care. Maybe you've done a pristine risk-benefit analysis for someone who has pain that's impairing their function severely. And this is going to go on for an extended period of time. The FDA says they have to be opiate tolerant, meaning they've been on opiates for a period of time and are tolerating them. So the FDA says you have to have been taking at least 60 milligrams of oral morphine a day, or 30 of oxycodone, or 8 of hydromorphone for a week or longer before you should start thinking about a long-acting agent. So again, they're trying to tell you not for acute pain, not for short-term pain, but for long-term pain if someone's already been on established doses of opiates. Uncontrolled pain must be controlled via short-acting IV or IV opiates before starting a long-acting agent. I know everyone's so well-intentioned. Someone comes in, they're in pain, give them some short-acting stuff or IV, and you say, let's put them on a long-acting agent. Again, it's well-intentioned, but you don't know necessarily what dose of long-acting agent they'll need. They haven't really established that they require long-term doses. Sometimes we start these long-acting drugs a little bit too prematurely in my observations. Okay, a patient is admitted with severe pain due to metastatic cancer. He or she continues to have 10 out of 10 pain in hospital day 2. Never been on opiates before other than what you're giving them. So you order 25 fentanyl hour patch, and in hospital day 3, pain is still 9 out of 10. Now the fentanyl patch is increased to 50 micrograms per hour. So you've doubled it over the course of 24 hours. So what could be done better? Why is this not an ideal scenario from what we've talked about? Fentanyl's a long-acting agent, right? So where's the short-acting stuff? Tell me what you're doing with the short-acting drugs to better control their pain. Don't start with the long-acting agent until you've really gotten a handle on their pain with shorter-acting agents. Premise number 1. Number 2, fentanyl was doubled in 24 hours. Earlier on, we said that fentanyl probably should not be up-titrated for 72 hours. Again, I see this done all the time, very well-intentioned, but you're not fully sure what that 25 microgram per hour patch is going to do the next day. Okay. So long-acting sustained-release opioids are not for acute pain management. They're not for acute post-operative pain. They're not for short-term pain. This includes transdermal fentanyl. Use short-acting agents before you start long-acting agents, and then dose escalate transdermal fentanyl no more than every 72 hours. Are there exceptions to the rule? Will we do it on palliative care? No, yes. But again, you have to really have thought about the rationale why you're doing that. How many of you have prescribed transdermal fentanyl so far? Okay. So just a few factoids about it. When you put a patch on, when does it kick in? About 18 to 24 hours. So it takes a while to kick in. Fentanyl is a little reservoir in the patch. There's a semi-permeable membrane. There's a diffusion gradient between the patch and the patient's skin. Fentanyl is very lipid soluble, so it can go from the patch through the semi-permeable membrane and start diffusing through the epidermis, into the dermis, into the subcutaneous adipose tissue, forms a depot in the fat, then it gets taken up by vessels and systemically sort of disseminated. That takes 18 to 24 hours. So if someone is on a short-acting agent, morphine, 5 milligrams every 4 hours, 10 milligrams every 4 hours, you start to put a fentanyl patch on them. Remember, that patch won't take effect for about a day, roughly 18 to 24 hours. Patch strengths are 25, 12, 50, 75, and 100 micrograms per hour. That's the units. When you put a patch of 25 on, 25 micrograms per hour fentanyl is released during that day. Little factoid, what dose of oral morphine in a 24-hour period is equivalent to fentanyl 25, meaning your resident says, let's put a 25 patch on this patient. How much morphine or its equivalent should they have been tolerating for you to say, okay, I'm gonna put that patch on this patient. I will use my Epic privileges and put on a 25 microgram per hour patch. Any thoughts? So this is a nice rule of thumb, not too much to remember. 50 milligrams. So there's about a 2-to-1 ratio. 50 milligrams of morphine in a 24-hour period is roughly equivalent to a 25 microgram per hour patch. This is actually called Levy's principle for transdermal fentanyl dosing. So if you're going to put 100 microgram per hour transdermal fentanyl patch on, that's equal to about 200 milligrams of oral morphine in a 24-hour period. So there's a 2-to-1 ratio. So easy way to kind of figure it out. Do you adjust for cross tolerance? Well, if I go from Dilaudid to morphine, I would have adjusted for cross tolerance at that point. But once you figure out the dose of morphine, you can go ahead and convert that to your 2-to-1 fentanyl dosing. Questions? Yes. Yeah, so good question. So if someone is in pain, use a short-acting drug. So I make the analogy of Lantus and Lispro insulin. If someone's sugars are uncontrolled, you're not going to give them multiple doses of Lantus and change the Lantus every 12 hours. You're going to pick a dose of Lantus. Yes, you'll titrate it, but you're going to use Lispro, short-acting with meals, Lispro correction factor, and you're going to crank up the Lispro if someone's blood sugars are 400. You're not going to rely on that Lantus from 24 hours ago. And so to me, short-acting opioids are like Lispro, and Lantus is like a long-acting agent. You're not going to rely on that to get the acute blood sugars way down. Long-term, it's going to be effective, but short-term, you're going to rely on the short-acting stuff. So if someone's pain is uncontrolled, the short-acting is what you would titrate. And then when all is said and done, you'll see how much short-acting they're needed, and then you can convert that into another dose of fentanyl. Questions? A patient has been hospitalized for 7 days. His pain is controlled on immediate acting morphine, and a decision is made to transition to long-acting opioid. So you put him on morphine, long-acting, 45 milligrams POQ 12 hours. And they need a breakthrough dose. What does breakthrough pain medication mean?
Covering a reduction in dosage between doses.
So someone's on a long-acting agent, they may have extra pain, right? The long-acting Lantus, if you will, maybe holding, it's giving them Lispro. It's giving a short-acting agent for pain above and beyond what is
alert. Tube system alert, main campus.
So they need something in between that long-acting dose, or in addition to long-acting dose. That's a short-acting agent. So if someone's on long-acting morphine, here we give options. They're asking you, should you use, well, they're giving you options of morphine. We can use any short-acting opiate for breakthrough. So most of the time, someone on long-acting agent is also on a breakthrough agent. So A is not correct, because you probably want to have them able to take something if they're having more pain despite their 45 milligrams of morphine Q12 hours. So what's the right dose of short-acting agent? You can notice they're all dosed Q4 because that's what a short-acting agent is dosed. But what's the right dose? Any thoughts? I'm going to give you a little formula. So breakthrough dosing. The long-acting opioid dose is figured out. So in this case, it was 45 milligrams of morphine Q12. That's 90 milligrams of morphine, long acting a 24-hour period. The breakthrough dose is 10 to 15% of the long acting 24-hour dose. So that's a quick formula. You know, you can see patients on kind of wonky doses are not always on this precise formula, but that would be what we put them on. So morphine 10 milligrams is about 10% of 90 milligrams, and that would be the short acting dose every 4 hours PRN. Questions? Okay. A 42-year-old woman with diabetes type 2 and end-stage renal disease on hemodialysis is post-op day 0, status an ORIF for hip fracture. She's admitted to Gen Med because she's on dialysis and ortho doesn't want to deal with that. Which medication should be avoided in this patient? Hydromorphone, morphine, fentanyl, or methadone? Anybody want to wager a morphine? Why? Yeah. So if we look at what drugs to use or not use in someone with renal insufficiency or renal failure, advanced CKD and stage renal disease, this was a great paper if you're interested doing renal, having a lot of renal patients from the American Journal of Kidney Disease in 2017. It sort of summarized what you do. So bottom line, they're giving you all the opiates we've talked about, except morphine, because morphine essentially should not be used in someone with advanced kidney disease, especially long-acting morphine. The metabolites are not dialyzable very well. The metabolites hang around, and there's a risk of seizures. There's a risk of CNS effects and just too much morphine and its metabolites floating around. So they also kind of tell you that, you know, dose adjustments for mild kidney disease, not too much, but as you get more and more severe, you probably have to watch the dose and sort of extend the interval. But again, morphine is not on this list. So if you take a look at just some principles, not recommended morphine and codeine. Why? Because codeine's metabolized to morphine. Use oxycodone and hydromorphone with caution, but you can use them so long as you lower the dose in the interval. The safest is fentanyl and methadone. Okay, methadone, we're not going to talk about. That's a hard drug to use, but is not renally cleared, so it's okay. But methadone is not a starting opiate unless you know what you're doing very well. Fentanyl, kind of rough, right? We have IV, we have transmucosal, which you can't prescribe unless you went through this risk mitigation system, and you have transdermal. So while these are the safest, and maybe fentanyl is the safest drug for someone who needs a long-acting agent, you're probably going to have to rely on oxycodone and hydromorphone at cautious dosing. Question?
Where's hydrocodone on?
Yeah, it doesn't appear in the literature. I would still probably use it with caution, but didn't make the paper. Did it make the paper here? No, didn't make the paper, but I think hydrocodone is okay. Cirrhosis. Again, a nice paper, a little older, 2010 Mayo Clinic Proceedings, still the nicest one that I've seen that talks about opioid dosing and pain management in someone with cirrhosis. Bottom line is you can use acetaminophen at reduced doses, no more than 1.5 to 2 grams. If someone NSAIDs are just bad, right? They can cause renal dysfunction, volume overload. So avoid NSAIDs. I'd rather avoid an NSAID rather than acetaminophen in someone with advanced liver disease. And opiates should use sparingly and at infrequent doses. They can precipitate hepatic encephalopathy if someone already has a substance use disorder, and sometimes they do with alcoholic liver disease. Has to be cautious. If you have done a risk-benefit analysis, you're going to use opioids, use at reduced doses and prolonged intervals. They don't tell you which ones, necessarily the best to use or not. You can probably use most. Again, if you're running into renal dysfunction, avoid morphine. But best you can use them sparingly and just watch out for side effects, especially precipitating encephalopathy. Questions? Okay, how many of you used a PCA so far? Okay, so I'm just going to go over it quickly. A PCA, patient-controlled analgesia indication, someone who has severe pain and the oral route is not feasible. They have incident pain or pain that is not predictable. Again, someone on ONC has, bone metastases, initially trying to get a handle on their pain. They get up and they're in excruciating pain. It's nice for them to be able to use the PCA. And if someone has severe pain, you can kind of help dose titrate and to maybe help find the proper regimen. Contraindications, if a patient can't figure out how to use the PCA, if they refuse to use the PCA, Or if you're just going to use opiates IV for a short time, if someone's going to be better in 24 hours, there's probably no need to start a PCA. But just so you're aware, when you put a PCA order set in, you have to pick the opioid, morphine, Dilaudid. Can we do fentanyl on the floor now? Or is that only still the unit? You know, I think it still might be the unit. Concentration of the drug, they come in different concentration vials. Pharmacy will help you with that. Demand dose is the dose the patient gets when they press the PCA button. Lockout, generally a lockout is how often the patient can get the dose when they press the button. 10 to 15 minutes is probably the standard lockout for someone who presents with acute pain or acute and chronic pain. Basal rate is a continuous infusion of the drug. Morphine in milligrams per hour, Dilaudid in milligrams per hour. A basal rate is not indicated and is inappropriate for someone who is not already on opiates. Someone comes to you from home on long-acting morphine and morphine breakthrough, and they're throwing up and they're in acute pain, they will benefit from a basal rate. Someone comes in, not on opiate therapy, do not start a basal rate. It's like starting Lantus saying, oh, I'm going to start someone on, well, there's weight-based algorithms. So pretend there's no weight-based algorithms. Okay, negate that. But you're just going to say, oh, I'm going to start someone on 15 milligrams of Lantus because they look like they need 15. That's what it is to start a basal rate when you don't know how much opiate someone needs. So no basal rates. Loading dose is an IV push of a drug to get someone sort of under control like you would, if you're not starting a PCA, 2 milligrams, IV push every 30 minutes because that's peak for a couple of doses. That's what loading dose means. And 4-hour limit is whatever number you put in there, a patient, once they exceed that amount, you will get a call. So if someone's getting 5 milligrams of IV morphine, that's the demand dose. Lockout is Q 15 minutes. In 1 hour, they can get 4 doses of morphine. In 1 hour, that's 20 milligrams. In 4 hours, that 4-hour limit would be 80 milligrams. Now you may say, I'm fine with that. You may say, gosh, I'm going to lower the dose by a little bit because I just want an extra safety factor in there. So 4-hour limit is sort of, I don't put a lot of credence in it, but just know that that's something you can calculate based on what they get and downgrade it a little bit, or quite frankly, if you ignore it, it'll go to what the concentration and amount of drug in the vial is. Questions about this? This is just a brief introduction so you know what you have to put in, or at least think about. Okay, he who writes the opioid prescription writes the bowel regimen. Very important. I have admitted many patients to Gen Med, miserable with fecal impaction. Onc patients are going to come in and, they haven't pooped for a long time and they're afraid of opiates, but we can combat that fear. So again, opioid receptors on the gut, when a drug binds to the mu receptor, they reduce peristalsis. They actually impair absorption of fluid from the bowel and impair secretion. So that's what opioids do on the gut, and all opioids will do that. There's some debate, does fentanyl, transdermal causes much constipation? Assume it does. So stimulant laxatives, Senna and bisacodyl, they're stimulate laxatives, so they stimulate the gut. When mu receptor stimulation stops the gut from being stimulated. That could be your first go-to. It can cause cramping, so some patients are uncomfortable from it. Or use a stimulant laxative like Miralax, milk of magnesia, or lactulose or sorbitol. Miralax is sort of our go-to here. Milk of magnesia, caution in renal failure because the magnesium can kind of build up. And lactulose and sorbitol are sweet sugars, which can make people gassy. So Miralax tends to be our go-to. Questions? This was a patient I admitted to Gen Med with a nice fecal impaction, and he couldn't pee because his rectum was compressing his bladder outlet. And this was from being started on opioids and not a laxative. Just a note that docusate by itself, what is docusate or colase? It's a stool softener. So it's combined with Senna and Senna S, but there's this whole big movement that it is unnecessary. It does not do anything by itself. So I know there's commercials on, keep yourself going, but for our patients who are in the hospital, sick, got bowel issues, don't prescribe just colase and expect it's going to do anything. If it's going to be combined with another laxative, fine, but by itself, essentially useless. So this was an article from Hospital Medicine in 2019 saying, don't even have it available by itself in the hospital formulary. Do you want to go on for a few minutes? You guys have to go. A couple more slides. Forge ahead. Bottom line is a 46-year-old with chronic pain from whatever it is. At home, she's on NSAIDs or he's on NSAIDs, pregabalin, exercise. Patient has a history of alcohol use disorder and has been abstinent for 8 months. They come in with cellulitis, chest pain, and they say, whenever I'm in the hospital, my pain gets worse and I get IV Dilaudid. So this is this is my nightmare, because you want to believe the patient, you want to control their pain, but IV Dilaudid is not the right thing to do. A thing I learned in my travels is chronic pain cannot be fixed in the hospital. You're not going to cure someone's chronic pain. And I think you just have to remember that when patients come in with chronic pain, it may get worse. You can kind of lower the worsening, but you're not going to get rid of their chronic pain. And IV opiates, while we use them, not so sparingly, there is a time and place for them. And the slide I want to show you, this is from hospital, site of hospital medicine. You can get a copy of these slides. So what do you do when someone's saying, I need IV opiates? It's the only thing that works. I always get them. You're not treating me well. Acknowledge the patient's pain, acknowledge that, they are uncomfortable, acknowledge that you have to help them, but acknowledge that opiates are not the best solution for them. You're not trying to be their enemy or their adversary, but we're going to work on your pain with something else. Don't argue with them. They may have they may say, I'm leaving AMA, you have the right to leave the hospital, but I still am not going to give you the inappropriate medication, something I believe is not in your best interest. So these are the hardest discussions on Gen Med. Looking at Matt, he was with me on Gen Med, and I always cave, okay, I'll give you Dilaudid. So I need a resident with me to kick me and say, no, that's not the right thing to do. So final comment. So, not all pain is physical. Patients have emotional pain, they have spiritual pain, they have psychological pain. Cicely Saunders, anybody know who she is? She's a founder of the modern hospice movement. So she coined the term total pain: physical, emotional, social, spiritual. So sometimes all the opiates in the world, all the adjuvants aren't going to help someone, because there's more to the story. And sometimes emotional pain does manifest as physical pain, or that's how the patient expresses it. So just know that, drugs are not the only option. We use our psychologists here very liberally. I think they're wonderful to help patients kind of help us sort through, are there emotional contributions to their pain? We can give them strategies for, cognitive behavioral therapy is a long-term relationship, but maybe some distraction methodologies, or kind of help them work with their pain in addition to what we're doing for the physical pain. Chaplains also can be very helpful when someone's really suffering from more than just the physical. And that is all I have. Comments, questions? Go and cure pain, but not chronic pain, and watch who you use opiates with, and don't fill anybody's kidneys with NSAIDs and their liver with Tylenol. Thank you.